Well, that was a great introduction. Thank you. I hope everybody enjoyed that as much as I did. I think that was a perfect overview that set the stage for today. Now, we're supposed to have a chair, Dr. Shireen Izat, starting this session. Unfortunately, Dr. Izat is not yet here because he's giving a competing talk on NETs in London, Ontario, but he will be here soon. And he's asked me just to chair this session in the interim. So I want to invite, I'm Sylvia Asa. I'm a pathologist. I work here in Toronto, one of the many members of this multidisciplinary team. And I would like to invite us to have a nice session now attacking one of the questions that you just raised, Dan, and that is about medical therapy for NETs. And we have three excellent medical oncologists who are going to give us talks today on different subjects in medical oncology. We're going to hear from Dr. Hagen Kennecke, who's here from BC, Simran Singh from Toronto. We heard a little bit from Simron yesterday. We all heard about Hagen yesterday from his patients, so thank you. And Dean Ruether, who's here from Alberta. So you can appreciate that we are getting across the country, and we're going to go through all different kinds of medical therapy. We're going to hear about these three. I hope we'll have enough time for questions for all three of you at the end of the three talks. We have 45 minutes for this, but we're actually probably down to 40, so I'll ask you all to keep your talks on time. Hagen, you're up first. Can I invite you please to the podium? And you're going to tell us about chemotherapy for NETs, new developments.
All right, good morning, everyone. Thanks, Sylvia, for the introduction. Let me just figure out where I am here. Good. Great to see everyone. I know many of you were here yesterday and even more today, and it's going to be a fabulous day. So I was asked to talk about one of the things that probably has the least amount of data for neuroendocrine tumors, which is chemotherapy for NETs. And I'm going to ask the question, should we still use it given all the new treatments that we have? So I'll start by reviewing the evidence about chemotherapy, and that will not take long. And then I'm going to consider potentially predictive factors that may be there that we could use to decide whether or not we should use chemotherapy and whether or not it will work. I'll talk about quickly current practice and what we should be doing in the future. So this is a little teaser. We're still told that NETs are rare. James Yao gave a nice little summary at eNETs, for those of you who were in Barcelona a month ago, telling us and demonstrating that you guys, for those of you who have a NET diagnosis, you're in actually quite good company. There's 171,321 estimated patients in the US with that diagnosis. He's asking the question whether this is still a rare tumor as it is formally classified. In terms of how we treat this rare tumor, there has, as Danny was saying, been a proliferation of new treatment options over the past 10 years, which is an incredible progress. And as you will notice, so just a definition, when we say systemic therapy, we mean therapy for the entire body. So it treats hopefully, it treats all the cells in the body as opposed to just liver-directed therapy. And so as you can see, there's quite a few, octreotide, lanreotide, lutetium, and streptozotocin, sunitinib, and everolimus. And the next speaker is going to talk about the targeted ones. I was asked to talk about the streptozotocin temozolomide, which, as you'll notice, there's the least amount of evidence for. So again, my talk is a little bit easier maybe. But we still use it. This is one of the studies that has been shown to at least retrospectively indicate that there is a role for capecitabine and temozolomide and alkylator combination in PNETs particularly. And our colleague, John Strasberg, published a small study, but still a very impressive 70% response rate, 70% ability to shrink the tumor with that combination. This is a summary slide of some other work that have been done, and on your left, the second column, it describes the different regimens that were used in the different studies, and then it goes to the different tumor types. So pancreas, as you can see, is among the higher response rates, as mentioned in the last slide, that we can get. Ileum, you'll notice, so those are the typical carcinoid small bowel nets, the most common ones that we treat, is among the least effective in these studies. Bronchial is kind of in the middle. It does seem to be chemo-responsive, and then others. So that's pretty much a lot of the evidence. Oxaliplatin has been used by some of our colleagues in prospective studies, mainly in combination with 5-FU. And as you can see in at least 2 of the studies, pancreas again seems to be a responder. GI nets even responded. It's a bit of a mixed bag, and as well as some response with lung. So I personally haven't used oxaliplatin and 5-FU a lot for my patients, but it is potentially something we can use. So, I mean, my big question is, and I think the big question out there is how do we know when to use chemotherapy? I mean, Dan has already told you that it doesn't have a huge role, and I think we really want to know when should we use it. And I think there's 4 different ways that potentially we could use. We're exploring and asking the question as to whether or not these might be helpful. The first may be the Ki-67. And this is a Danish study that described at least for G3 NECs, not NETs, but NECs, asking the question, how does Ki-67 influence the response to chemotherapy? And if patients are treated with platinums, which is a little bit more of a toxic regimen, if their Ki-67 wasn't quite high, i.e. above 55, they actually didn't respond to it really well. And that raised one of the questions as to maybe even for NECs, which we usually say platinums, reflex answer, maybe for NECs, it's not a one-size-fits-all story. And the question has come up whether these lower Ki-67 tumors should be treated with alkylating agents. And I'm going to tell you about a study that's looking at this question later on in the talk. The next hypothesis is asking the question whether MGMT might predict response to temozolomide, i.e. alkylators. Now, MGMT basically counteracts the effectiveness of, it's an enzyme which counteracts the effectiveness of temozolomide. Temozolomide is a methylator, and MGMT is a demethylator. And so what Matt Kalki, who was a really smart guy, did, he stained about 100 nets, and he found that almost all, actually none of the, other way around, the carcinoid tumors, so the small bowel nets, all of them had this enzyme that works against the chemotherapy that we like to use. However, half of the P nets actually did not have that enzyme, which might go a long way into explaining why chemo, or at least temozolomide, does not work in nets, small bowel nets, but it does seem to work much, much better in PNETs. And as you can see on below, there's the response rate with PNETs in that same cohort was 35%, and with carcinoids, it's been only 2%. So really, that's some really nice scientific evidence. It raises a hypothesis, and we'll again get back to that. We talked about yesterday about the role of FDG PET, so glycolytic PET, in potentially guiding chemotherapy. And I think that can have a huge role where patients with the classic glycolytic PET avid disease may be much more suitable for cytotoxic, more aggressive chemotherapy than those where the PET scan is negative. So, which I told you about the study we're doing, so we're going to look at prospectively what is the value of an FDG and a gallium PET to help improve our decisions in patients with newly diagnosed NETs. This is a huge new thing that came, that's almost all they talked about at eNets this year and in Barcelona. And basically, the pathologists have come up with a new way of classifying NETs. And it's actually just a revision, but it's a good one. And it's kind of overdue, I think. And I think the hope is that this is going to decrease net confusion and improve our way to classify tumors and decide whether or not they need chemotherapy. So in the past, up until 2000, or as of 2010, pathologists said if your Ki-67 is less than 20, you're either G1 or you're G2 net. But they said if your Ki-67 is greater than 20, then you're automatically a G3 and NEC and you're not a net. And many of us knew that that was just not true, because we know that many of patients with higher than 20 Ki-67 still had well-differentiated tumors, and they behaved like nets and were nothing like neuroendocrine carcinomas. So it took them 7 years to realize that there actually is a such thing as a G3 net, and so that category now exists, and we can use that in treating our patients. And in case there still remains some confusion, there is, particularly in patients with PNETs, we can do some genomic testing, and we know that patients with PNETs have some very traditional or very consistently conserved mutations. DAX, ADRX, MEN1 are some. For my patients with PNETs or NETs, if there's confusion about where they came from and are they an NEC or are they a NET, I often offer panels. These panels are available either from your hospital, or you can send the tissue to the United States for a fee. And that can really help our diagnosis and ultimately our treatment and potentially our decision of whether or not you should give chemotherapy. If they are NECs, you can also do P53 and RB1. Maybe Sylvia's going to tell us about that later. So overall, in terms of my conclusions about chemotherapy in general, this is kind of how I practice. So PNETs, the principle really is they're generally chemosensitive. Other GEP-NETs are generally not. That's the kind of default position, really. I think there is a question out there, bronchial tumors, bronchial NETs, may be a little bit more chemosensitive. Alkylating agents are particularly relevant in PNETs, and that's the temozolomide, dacarbazine, and streptozotocin. Platinum-based chemos are the ones we should use for NECs. However, maybe only for those with high Ki-67. And FDG glycolytic PET may be a really valuable role for chemotherapy. And finally, I think the WHO 2017 classification is going to decrease net confusion. This is the last couple slides are about the future, and we heard yesterday is trials now are what we're going to do in the future. And there's 3 studies I'm going to tell you about going on right now, looking at chemotherapy and the role it may play. This one has been accrued, and it's for patients with PNETs, and it's asking the really simple question is, should we just use temozolomide for patients with PNETs, or should we also use temozolomide plus capecitabine? Really interesting question, very practice-changing when and if it reports. And they will also be looking at the MGMT question, whether or not that should be used as a predictive factor. And it could be that it's only the PNETs without MGMT that respond to temozolomide, and so then all the other people who have the MGMT, we shouldn't treat them, and it'll spare a whole bunch of people a whole bunch of toxic therapy. The next trial is on for NEC patients, so these high-grade tumors. I'm going to tell you this is the first trial that is actually prospectively done in NECs, because they're not that common and they are hard to treat because the tumors are quite aggressive. And it's asking the question of whether we should treat them with capecitabine, temozolomide, or cisplatin and etoposide. And it's also going to go back to that question as to, is there a cut point in terms of Ki-67 that we should be using to decide between the two? Is it really a one-size-fits-all either-or is it a more complex question? Finally, this is an Australian study. I love the Australians. This is a great study. This is a great trial. And it is asking the question of what is the value of chemotherapy added to PRRT or chemotherapy versus PRT plus chemotherapy. It's a bit complex. The slide's a bit busy, but basically they're trying to ask the question of, if you have a PNET, do the patient do better if you give chemo up front or chemo plus PRT? And if you just have a NET, should you be doing PRT alone, or should you be adding a PRT plus chemo? This is a little bit more relevant only for the Australians, because they tend to add chemo a lot to PRT, and I think that's a very promising thing to do. So good for them for doing that prospectively. So overall, I think systemic therapy is a role we're going to hear. I think Simron's up next. He just came in. It's a bit early for a Sunnybrook medical oncologist, but I think he's here now, and he's going to tell us about the targeted agents. And I brought back Nemo and Dory. They were very popular yesterday. Do we have time for questions? We'll move on.
And can you stand for it?
Can I what?
Oh, yeah. The panel. Questions. Thank you so much, Dr. Kennecke. As you heard, our next speaker is Simran Singh, who's here from Sunnybrook in Toronto. Simran is going to tell us now about the biological agents that are biologically targeted drugs for medical therapy in this disease. Simran.
Thank you. And yeah, Hagen, it is a bit early for me, actually. It's true. I'm not going to lie. And we're going to miss your wonderful sense of humor when you leave to the States and join Trump in his crusades, yeah. So me and Hagen are actually really good friends. I'd say. So I'm going to talk to you today a little bit about biological targeted therapy. So Hagen was talking to you about chemotherapy and its uses, and I think gave a really nice summary of the possibilities of chemotherapy and where it can grow. I'm going to talk a little bit about biological therapy and about the different ways that targeted therapy could potentially impact disease. So my goals today are to discuss the changing landscape, a little bit about NETs, and to give a quick overview of that. I'm going to review the treatments and some of the evidence. I warn you in advance, there's going to be a lot of graphs, a lot of data, and the point is not to memorize numbers or to look, but to really look at just the magnitude of effect and to be convinced that when these treatments work and on what indications. And then I want to see how we can maybe integrate some of what we're hearing today into what we call individualized treatment for NETs. So times are changing. This was the Prime Minister when Hagen was born. And as you could see, if that was NETs before, this is NETs now. So things have changed dramatically. Things are very different, and we've made a lot of progress. So, you know, the neuroendocrine tumors were first diagnosed or first described in the 1900s. This word carcinoid comes from a German word that means cancer-like, and I think that's been a disservice that has been done to the NETs community since that time, because this idea of cancer-like has sort of taken away attention from the possibilities of NET as a malignancy. And then we started to get our first treatments not really until the 1980s, where streptozocin was one of the first drugs that was used. It's interesting to look at the trials with streptozocin. If you look at them, they certainly wouldn't be accepted in today's standards. There was a lot of bias in the trials, and the way that they were done was actually a not blinded study, which meant that people knew what treatment they were getting, which could influence the outcome. We then started to get treatments that were a bit more targeted when we looked at the somatostatin analogs, and another speaker is going to talk about that. And then we started to really see some movement happen, as Hagen was saying, the last 10 years or so. We started to see the first phase 3 trials in NETs. So before this, we were told that phase 3 trials in NETs are not possible, that it was impossible to do a phase 3 trial in NETs. The tumors were too different, there were too few patients, and this would just never happen. And this idea should be ignored, that we could ever get good data and try to figure out what to do in NETs. And up to this point, I would say that NETs were sort of treated in best clinical judgment. We didn't have evidence to drive. And that really started to change with the PROMID study, the RADIANT-3 study, which I'm going to talk about, the sunitinib study. And then in the last couple of years, you could see we have a large new studies that have come through, such as the CLARINET study, which looks at lanreotide, and then the RADIANT-4 study, which I'm going to talk a bit about today, which looks at everolimus. But as you could see here, we've had a lot of new studies that have come about, and so things are really looking good in terms of developing new studies. And that has led to a couple of guidelines. And for people who haven't taken a look at this may be worthwhile taking a look at. We have 2 sets of Canadian guidelines, which many of the speakers, almost all of them, have been on and have been participating in. One looks at pancreatic neuroendocrine tumors. One looks at gastrointestinal neuroendocrine tumors, and we're hoping very soon to have a lung neuroendocrine tumor guideline. So this evidence hasn't gone unnoticed. We've been able to integrate that and build that into a set of guidelines, which hopefully can be used around the country to help drive best practice. So some of you saw this slide yesterday, and some of you are probably still hurting from the Toronto Maple Leaf loss yesterday. And some of you are looking forward to the Oiler win tonight. But you'll see that neuroendocrine tumors are very different. So we talked a little bit about this yesterday, about the idea that we should individualize treatment, and not all the treatments are going to be the same. As Hagen sort of alluded to, for some patients, chemotherapy will be the right option. For some patients, somatostatin analogs may be an option. For some, targeted therapy may be an option. And that's why it's important to be able to look at all the different factors we described and to be able to characterize what kind of tumor we're dealing with so we can treat it effectively. And this is sort of our plan at Sunnybrook and how we're doing this. And that's why I think, as Danny was saying this morning, you really need a multidisciplinary team. You need a surgical oncologist, a medical oncologist, an endocrinologist, a whole team that's able to help characterize these features so that we can offer the best treatment. So I do want to make it really clear that biological treatment is not for everybody. It is not the right treatment for everybody. It may be part of the right treatment plan, but treatment plans need to be individualized. So what are our goals when we're looking at therapies, especially biological therapies? Well, of course, we want to improve quality of life. So we need to think what the side effects of these therapies are. What are they doing? What are we getting in return? So what are the positives? Well, we're increasing survival. Are we stopping the tumor from growing? Are we controlling symptoms? So what are we getting and what are we paying? What price are we paying? And I don't mean only financial, although for many people, financial cost does come into play, unfortunately, for neuroendocrine tumors, but also in terms of life, in terms of quality of life. So when you hear about these drugs, I want you to keep that in mind. So I'll first talk about Everolimus. So I'm going to talk pretty much about two targeted therapies, Everolimus and sunitinib. Everolimus is what we call an mTOR inhibitor. And it's been recently studied in this trial, the RADIANT-4 trial, which some of you heard about yesterday. The RADIANT-4 trial looked at patients who had advanced progressive, so that means the cancer had to be growing. So I just had this discussion with a patient this week. They wanted to start this treatment even though their cancer hadn't grown for a couple of years. And we had a good discussion about whether it was worthwhile starting a treatment when their cancer wasn't growing currently. So everybody on this trial had their cancer growing. So that's a really important fact, right? Is your cancer growing or is it not growing? In this trial, everybody's cancer was growing to be entered into the trial. It included all lung and gastrointestinal nets. So a wide spectrum of patients. When we talk about PRT, we're talking about a much more narrow spectrum of patients. We're talking about people who have small bowel, midgut tumors. Here we're talking about all gastrointestinal and lung neuroendocrine tumors. Pardon me. They were randomized to receive everolimus or placebo. It was a 2-to-1 randomization, but 1 out of every 3 patients received a placebo. When the trial results came out, everybody who's on the placebo arm moved to receive everolimus. And these were the results. They were pretty significant. Okay? This means a 52% risk reduction in progression of your disease if you're on the everolimus arm. So clearly, this was a very efficacious study. And based on this, Health Canada has approved this drug for use in all GI as well as lung nets. Unfortunately, there is not access to this drug right now, in Ontario at least. I shouldn't speak for the whole country, sorry. In Ontario, at least, we do not have access now, so I would encourage that's one of the things CNETs could get involved with, is to ensure that we get funding for this drug, because I think it's important that all patients have at least a spectrum of these treatments available. When we looked at who responded, we saw that some patients who had previously received somatostatin analogs, they seemed to respond. Some other patients who had not received somatostatin analogs also responded. And then coming to the side effects, I think this is very important. It's great that this drug works, but we also need to take into account what side effects they are and what potential impact that could have on people. Mouth sores, what we call stomatitis, was the most significant side effect. 63% of people reported some mouth sores, and about 10% of people reported very severe mouth sores, which could actually impair with eating and nutrition. I've actually had people who've actually had very severe mouth sores on the drug before that needs to be managed. Other common side effects were diarrhea. About 30% of patients reported some diarrhea. About 30% of patients reported some fatigue, but you'll notice that even those people who were not on the drug, about 25% of patients reported fatigue as well. Infections and rash can also be common side effects. So although this treatment works, we do have to be able to take an active approach to the side effects. And one of the things we do look for when we're using this drug very cautiously is to ensure blood sugar, which can also go up. So for patients who are diabetic, that's important to look at. And cholesterol and lipids, they can also go up. So they need to be monitored regularly if you're on this treatment. We have yet to see what we call an overall survival advantage, which means we haven't seen yet that it improves people's life. It stops the tumor, we know that. That doesn't necessarily always equate to people living longer. But what I will say is that because everybody on that placebo arm ended up getting the drug, as they should have ethically, it may sometimes dilute the difference. And so we may not actually see this, but we clearly know that giving the drug can stop the tumor in a majority of patients. So as we were saying, we want to look at not only the treating all NETs as one. So instead of saying blanketly that we want to look specifically at Everolimus as a treatment for all NETs, I want to look at some of the subgroups. And so if we look at the GI subgroup, we'll see that it worked. You can see the two curves here are different. And then we looked at the midgut subgroup. You'll see maybe the curves aren't as separated as they were in some of the other areas. So for the midgut neuroendocrine tumors, we have two options here. Everolimus appears to work. The advantages of Everolimus, it's an oral treatment. It's a pill you take every day. It may be more convenient for some people. You can take it at home. But we've also heard about PRRT, or you will hear about PRRT, and it also works very well for the small bowel neuroendocrine tumors. A bit different. You have to come in. In most places, you're overnight. You get radiation, but it's only 4 cycles, and you're home at different points. And those treatments may work differently for different people. They may fit different people's lifestyle. So you have options, and I think those are some of the factors to consider. When we look at bronchial or lung NETs, it is actually the most common type of NETs. If you look at all the different sites, it is the #1 site of neuroendocrine tumors. And to date, there's been no standard treatment. We often use somatostatin analogs, looking at to see if they're effective or not. That's octreotide and lanreotide, but we really haven't had any data. There's an exciting trial called the SPINNet trial that's being done now, and I think there's multiple people in this room that are participating in that trial that looks at lanreotide in lung neuroendocrine tumors, and that's the first trial dedicated to lung neuroendocrine tumors. So I think that Ipsen's done a great job there. So when we look at for the RADIANT-4, we look at the lung neuroendocrine tumors, you could see that there really is, the curves are really far apart. So I think this has become the standard of treatment for patients who have progressive disease. So right now, I think if there's a progressive disease, lung neuroendocrine tumor, there's 2 choices. One is to go on clinical trial on the SPINNet trial, and the second would be Everolimus. And this is great because we didn't have either of these options just a few years ago. When we look at the side effects for the lung neuroendocrine tumors, you can see here that the side effects are pretty similar to what we saw on the overall trial. Mouth sores, rash, fatigue, a little bit more edema, which means a bit of more swelling in the ankles, potentially than in the larger group. But it appears the side effects are pretty consistent. And the more we see a similar pattern, the more we feel confident about the side effects and we know what to expect. So that is looking at GI and lung neuroendocrine tumors, and that's the more recent trial. There's quickly, I just want to bring up 2 other trials to you, and that is the RADIANT-3 and sunitinib trial. This is specifically for pancreatic neuroendocrine cancers. These are a bit older, and I think these drugs are available almost throughout the country. They're funded throughout the country. Excuse me. So that actually is a huge advantage for us. The RADIANT-3 study looked at the same drug, Everolimus, and it looked at pancreatic neuroendocrine tumor patients. 410 patients. So I think that really proved that you can do well-conducted trials in neuroendocrine tumors. Again, patients had to have progression in the last 12 months, which means their tumor had to be growing, and they were randomized to either receive Everolimus or placebo. And these were the results. Again, you're seeing almost a 65% risk reduction in the progression of disease for pancreatic neuroendocrine tumors. And that goes along with what Hagen was just telling you, that pancreatic neuroendocrine tumors, fortunately, do respond well to both chemotherapy and biologic therapy. The side effects are very consistent to what we've seen before, so I don't think I'm going to review them again, but it gives us a consistent side effect profile. And then the last study I want to bring up really is the sunitinib trial, which looks at another drug, called sunitinib or Sutent in patients with pancreatic neuroendocrine tumors. Now, this drug has been used quite a bit in renal cell cancer, and it's been probably established most strongly in renal cell cancer. There, they give a dose for 4 weeks on and then 2 weeks off. So you get a larger dose for 4 weeks and then a 2-week break. This dosing was a bit different. It's a dose of 37.5 milligrams a day, every day. Okay, so there's no built-in break. Again, pancreatic neuroendocrine tumor patients that had progressive disease. This trial was a bit smaller than the other trial. As you could see, it was at the end of the day, it only had 171 patients. And there was a little bit of difference in terms of how the trial was conducted and analyzed. And there's a bit of debate about whether, but I think both drugs have been proven to be efficacious. You can see here as well, we saw a very similar, you could almost take the 2 graphs and overlap them, which shows that both these drugs appear to respond. The challenge we have for patients who have pancreatic neuroendocrine tumors is once we use one drug, we're often held back from using the second drug from a funding point of view. And I think to many of us in the room who are treating neuroendocrine tumors, it makes logical sense that if you use one, they have different mechanisms of action. One stops working, you try the other. So that's another area I think that advocacy work could be very useful. How are we going to decide between these two drugs? It really comes down to side effects. It comes down to how we're going to individualize treatment. For example, someone who has a lot of problems with their blood sugars, we probably wouldn't want to consider Everolimus. Someone who has a lot of problems with high blood pressure, which is the side effects of sunitinib, we probably wouldn't want to use that drug. Again, getting back to this concept of individualized treatment. I think you've just seen this slide from Hagen, so I will quickly go over it. What we're at right now is we have a lot of the gaps filled across the different types of neuroendocrine tumors, as well as a lot of different therapies. We still don't know. In terms of the targeted treatments, when you look at Everolimus, we see it works almost in all types of neuroendocrine tumors. When we look at sunitinib, we have good evidence that it works in pancreatic neuroendocrine tumors. I'm getting an X, that means I'm out of time, so I'm going to quickly go through where do we go next in terms of targeted treatments. I think we talked yesterday a little bit about clinical trials. These are some of the clinical trials that we're going to have across the country. These are some of them that we have this year at Sunnybrook, for example. So when you're looking at immunotherapy, using your immune system, potentiate your own immune system to target the cancer cells, a very exciting part of oncology that's really changing the face of oncology. We've seen dramatic differences in melanoma, in lung cancer, and it's really being tested in all types of cancer. We're going to have in Canada some of the first trials on immunotherapy in NETs in the world, which I think is great. As Hagen was saying, there hasn't been a lot done in the poorly differentiated high-grade neuroendocrine tumors. This will be the first trial in Canada that looks specifically at high-grade neuroendocrine tumors in immunotherapy, as well as we're going to have a trial looking at well-differentiated neuroendocrine tumors in immunotherapy. And Novartis has a trial that's coming through that we're probably going to have access to throughout the country, looking at immunotherapy after Everolimus. So a number of immunotherapy trials coming forward that we're going to have access to. Right now at Sunnybrook, we're currently running a combination therapy trial where we're looking at Everolimus as targeted therapy, combining it with radiation to the liver. Radiation, not PRT, but external beam radiation that you may hear about, has not often been thought of as an effective treatment for neuroendocrine cancers. We're hoping to use the two together, targeted therapy and radiation, to specifically target disease in the liver to be able to provide better outcomes. And through the CCTG, which is a large research collaborative across the country, there's a new drug, a new targeted therapy called cabozantinib that is being tested in the United States, and it looks like Canada will probably, I can't say for sure, but probably participate in that trial, which would be right across the country as well. So a lot of new trial options of targeted therapies for NETs. Great, thank you.
Thank you, Simran. I think we are getting short of time, so I'm going to invite Dean Ruether to come up and talk about somatostatin analogs. I don't think we're going to have time for questions, but let's see what we get now.
Thank you very much, and I appreciate the opportunity to be here today. I'm going to tell you a story about the somatostatin analogs. I hope what this illustrates to you is a success, but sometimes some of the frustrations we deal with in dealing with a rare cancer and trying to take steps forward in looking after patients with rare disease. So this is a relatively recent story. The somatostatin analogs, probably everybody in the room has heard that term, and many of you are on drugs that fit within this class. But it was only in 1973 that the molecule was first actually isolated from sheep brain, and it wasn't useful clinically because it doesn't hang around in the circulation for more than a couple of minutes. And it took a few more years before someone was able to synthesize a synthetic analog that could actually be administered to patients to help manage symptoms. And it was only in the mid-1980s that it was actually trialed in patients and shown to help control the symptoms related to carcinoid syndrome, that flushing diarrhea that patients complain about. And so those of us who treat this disease have seen the benefits in using these agents to manage patients who complained of the hormonally related symptoms that come with a diagnosis of a functioning carcinoid tumor. Most people recognize the term carcinoid, but these tumors sometimes produce other hormones that are responsible for some of the symptoms that our patients complain about. And we've seen an evolution of the use of these agents in the sense that prior to the availability of the somatostatin analogs, when we couldn't control these hormonally mediated symptoms, that's what patients died from, the complications that came with poorly controlled diarrhea. That, as a cause of death for patients nowadays, is quite unusual because we can control those symptoms. And so that has been a dramatic improvement over the last 30 years for patients who suffer from these hormonally mediated symptoms, and I think also has impacted how long people live with this disease, although it is a little harder to demonstrate that from the kinds of clinical trials that allow us to bring new treatments on board for people. But if we look at large data sets and look back at them over time, what we call a retrospective review, there's a suggestion there that these drugs have not only helped to manage symptoms, but also help people to live longer and with better quality of life. So they've had a role in that space for a long time. But I think equally important is a more recent recognition and data from clinical trials supporting the fact that these drugs also have a role to play in patients whose tumors are not functioning. They can help to slow the growth of a non-functioning tumor. And my colleagues have previously referenced a couple of clinical trials, the PROMID study and the Clarinet study, that have really helped to articulate the benefits of using these drugs in non-functioning tumors. I'm not going to belabor time on the graphs. These are the two trials that I think are the pivotal ones that demonstrate the importance of considering these agents in patients who have non-functioning disease. Targeting the somatostatin receptor is foundational to the care of patients with neuroendocrine tumors, and our ability to do that has had a dramatic impact on what we can bring to bear for patients. From the point of our ability to make a diagnosis, so using octreotide scans to identify where the disease is, perhaps where it may have come from, where it started. It's had an impact in terms of what we can do from a systemic therapy perspective, the octreotide analogs that I've mentioned. And PRRT, this form of targeted radiation that you'll hear about, relies on our ability to target the somatostatin receptor. So this is a very, very important, and as I said, I think foundational element of how we treat neuroendocrine tumors. We do need CNET's help. Across Canada, there are issues with access, appropriate access to the somatostatin analogs, issues of access to PRRT, and physicians and healthcare providers can advocate, but we need the patient voice to help move things forward in terms of creating more uniform access and funding for these agents. Our approval processes in Canada are relatively slow, and so it can take anywhere from as short as a couple of years to much longer for effective treatments to be brought into the clinical environment. It's good to be in a situation where we can ask these kinds of questions. You've heard about lots of different options for treatment that can be considered. What's often a challenge for us in providing care for an individual patient is trying to tailor that treatment and decide if we have the option of a tyrosine kinase inhibitor like Sutent, which you've just heard about, or an mTOR inhibitor like Everolimus, or if we've got access to PRRT or chemotherapy. What is the right sequence for an individual patient? Is there a best sequence for a certain individual? Recognizing that sometimes people aren't going to be able to get through all of these options. Their health may deteriorate to the point where we can't necessarily bring all options to the table. So let's make sure that we're using the best one up front for that individual patient. And I think those sequencing discussions and treatments need to be built on the background of targeting the somatostatin receptor, and the appropriate use of the somatostatin analogs. There are still lots of questions about the appropriate use of these agents. When do you start it? Particularly in a patient who doesn't have a functioning tumor. It's easy if someone is having symptoms with diarrhea and flushing that we want to try to control. Clearly, that patient needs to be on a somatostatin analog. But if you've got a patient with a very slowly growing tumor that is not functioning, and we're trying to get the benefit of controlling disease, unfortunately for an individual patient, that's not a question we can ever answer, because we don't have the crystal ball that says if we didn't have you on this drug, this is how things would look a year from now, as opposed to let's put the drug on board and see how things look 6 months, a year, 2 years down the road. And while these are well-tolerated drugs, it still means an injection given on a monthly basis. That ties up people's time. So when is the right time to start a drug like this? And then if we're layering these other treatments on top, as I said, what is the right sequence? And then it's exciting to be in a situation where we can start to ask questions about combinations of treatment. So can we give a somatostatin analog with a targeted drug like sunitinib or everolimus? Can we give it in combination with chemotherapy or with PRRT? And is it better to give those things all together, or are you just making treatment more toxic and tougher for individuals? Maybe it's better to sequence things. Maybe you get more bang for your buck and less side effects if you can roll over from one treatment to another, depending on how the disease is behaving. We need access to large databases to try to answer these questions. You've heard my colleagues talk about clinical trials, which for us in the oncology world are often the gold standard with which the tool that we use to assess the effectiveness of a new treatment. For patients with rare tumors, it can be very difficult to do large randomized controlled trials. And when we have the ability now to connect individual patients' data into large databases, we can use that to learn from real-world experiences. And we've seen that transform the care of patients with other types of rare cancers, kidney cancer being a very good example. Large databases in Canada and other places in the world have helped us to make the case for these are effective treatments, even though we don't necessarily have a phase 3 clinical trial that shows us the benefit. We need access to these treatments. And I will pause there. Thank you.
Thank you. I think in the interest of time and respecting the next speakers, maybe we'll just call an end to this session. I am sure that our speakers will be available at the breaks, whether it's coffee or at lunch. And if you have questions, hopefully you'll have an opportunity to talk with them. Thank you.